Hello, fellow nurses. My name is Janine and I'm an RN. Today in our discussion, I will be discussing jaundice and flat nipples. I'll be using a clinical decision-making framework to explore these health challenges and identify 3 priorities of care for the RN. The first step in our framework is knowledge. We need background knowledge in the pathophysiology of jaundice and what flat nipples are. The second step is to look at cues. Cues include our observations, assessment data, lab work, mother's feelings, and intuition. Third is judgment. Based on our cues, what is happening with these health challenges? Fourth, what decisions can we make to resolve or improve the health challenge? Can we involve other healthcare members to assist us? Finally, we will discuss how to evaluate our decisions and see if more changes need to be made. Now that we've reviewed the clinical decision-making process, let's look at the first step. Knowledge. What do we know about jaundice and what do we know about flat nipples? In order to assist all women with breastfeeding, nurses need to be able to identify what a flat nipple looks like in comparison to other nipples. A normal nipple protrudes outwards, as seen in this first illustration. The second illustration I'm about to draw depicts a flat nipple. Can women with flat nipples breastfeed? The answer is yes. It may take a bit more time and energy to get it right or find the technique that works, but it is very possible. The Leche League states that babies breastfeed, they do not nipple feed. So the type of nipple a woman has does not determine the ability to breastfeed or not, and that is very important for nurses to know when encouraging mothers to breastfeed. The third illustration here, for comparison's sake, is of an inverted nipple, where the nipple is inverted, and breastfeeding here is still possible. There are 3 types of jaundice in the neonate. The most common is physiological jaundice, which is mainly present because of an abundance of red blood cells in the newborn at the time of birth and an immature liver function. The second is breastfeeding jaundice. Breastfeeding-associated jaundice begins at 2 to 4 days of life and is due to inadequate milk take by the infant at the breast. The third type is pathological jaundice. If you see jaundice within the first 24 hours or 2 weeks after birth, it's most likely pathological and can be due to a variety of reasons that are not normal and need further investigation. Bilirubin is derived from broken down red blood cells in the liver. The liver produces bilirubin in a conjugated and unconjugated form. The unconjugated bilirubin is bound to albumin, pictured here as the little U squares attached to the A's, while the leftover unconjugated bilirubin in the blood vessel is insoluble and can leave the blood vessels. It goes into the skin and the sclera, creating a yellow color. The conjugated bilirubin is soluble and secreted by the liver as bile into the intestines. When the bile is not removed along by stool, an enzyme converts the conjugated bilirubin back into unconjugated bilirubin, which is reabsorbed and returned to the liver. With adequate feeding, peristalsis promotes the passing of meconium, removing conjugated bilirubin and reducing the overall level in the body so unconjugated is not reabsorbed. Now that we have reviewed our knowledge of flat nipples and jaundice, we will move on to the next step of the decision-making framework and see what cues us as nurses to identify these 2 challenges. How do we determine if a mother has flat nipples or not? You can help a mother determine if she has flat nipples by performing the pinch test. By placing the thumb and finger about 1 inch away from the nipple near the edge of the areola and compressing in towards the chest with a gentle squeeze. If the nipple does not become erect, it is considered a flat nipple. If it retracts, it is an inverted nipple. So what are our cues for identifying jaundice in the newborn? The most obvious answer is that the skin will appear yellow, but this isn't always easily identified in the darker skinned newborn. To identify jaundice, apply pressure to a bony area for several seconds and allow the capillaries to empty from blood. If the blanched area appears yellow instead of white, jaundice is present. Jaundice will first be seen in the head, face, and sclera. Looking at the sclera is useful when skin color is dark and hard to identify the yellowish color in the skin. The jaundice then works its way down the trunk, abdomen, and then towards the extremities. So testing for jaundice on the forehead or nose may be more useful than the feet if it hasn't made its way there yet. Assessing jaundice in natural light is better, because artificial light and reflections from the surroundings can distort the infant's skin color. Here's an example of someone assessing the skin for jaundice. On this side, they're blanching the skin and it's remaining white. On this side, they're blanching the skin and it's got yellow tinged. It's a little harder to see. That's because it's not staying white. So there's jaundice present. Other signs of jaundice include a sleepy infant who's not waking for feeds or when stimulated, decreased stool and urine output. The urine may appear darker if bilirubin is being dumped into the urine. Sometimes they'll have a high-pitched cry and high bili levels. Bili levels can be determined whether phototherapy is needed by using a bili graft. This tool is helpful in determining how severe an infant's total serum bilirubin level is and whether they require phototherapy or not. You can plot the level of bilirubin based on the infant's age in hours. Depending where they fall on the graph determines if they need phototherapy. 3 judgments could be made by the nurse working with a mother who has flat nipples and a baby with jaundice. Number 1 could be that the baby is having difficulty latching properly to the mother's flat nipples and therefore is unable to take the milk from the breast. The second thing is that the milk supply is not in yet and the baby is not getting enough milk. The third thing is there is a combo of the two. The baby is not latching properly and the mom's not able to make enough milk, and they're both contributing to increased levels of bilirubin and jaundice. This would be supported by the above cues and assessments made by the nurse and a bili level. If a bili level has not been drawn yet, the nurse should notify the physician and get a bili level drawn. Based on these judgments, the nurse has 3 priorities that she must address. First, establish a latch. Secondly, ensure there is a milk supply and/or increase that milk supply. And thirdly, provide adequate fluids to the patient. This baby needs fluids in order to reduce the bilirubin level. What decisions can we make to address these priorities of care? First of all, watch a feed closely and suggest position changes. Sometimes a simple change in a feed from this to this to this, different position holds can help achieve a latch for a woman with flat nipples. Make sure the baby is achieving a deep latch so that they're not just taking the first part of the nipple, but more of the areola into their mouth. Encourage frequent feedings. Breastfeeding takes practice, and offering the breast to the infant for at least every 3 hours increases the neonate's abilities and also increases milk supply. Other suggestions for flat nipples include nipple stimulation before feeds and cold compresses to erect the nipple. Pulling back the breast tissue before having the infant latch can help the nipple protrude as well. Various technologies exist that can assist a mother with flat nipples. Breast shields can be worn inside the bra while pregnant or between feedings to help the nipple protrude. Pumping and hand expression can also increase nipple elasticity and may be helpful directly before a feed to extend the nipple outward. Expressing milk can also increase supply. Nipple shields can encourage the infant to suck and draw the nipple out. Shields can be discontinued once the elasticity of the nipple increases and the baby gets stronger with improved breastfeeding technique. If the latch and milk supply is still an issue, consider supplementing with mom's own expressed breast milk, donor milk, or formula, especially if the bilirubin level is high. It is important that the infant receives enough fluids to pass stool and remove the conjugated bilirubin from the system in order to prevent life-altering effects from hyperbilirubinemia. Regardless of supplemental feeding, breastfeeding can always be supported even when phototherapy is initiated. Encourage breastfeeding for 15 to 20 minutes at feedings. Skin to skin at this time can help the baby latch and the milk supply increase. Once we have decided what aspect of the breastfeeding challenge to change, we can evaluate the effectiveness of that change by asking ourselves, is the jaundice line visibly receding? Are outputs improving? Is the baby more alert? Is the latch improving? Is the breast milk supply increasing? Is the bili level coming down? From here, nurses can evaluate whether another decision or change is required. That concludes my discussion on this breastfeeding challenge. By using the situated clinical decision-making framework, I was able to identify knowledge and cues that led us to judgments and 3 priorities for nursing care. 1. Establish a latch. 2. Ensure and increase a milk supply. And 3. Provide adequate fluids to the infant. I discussed some decisions and changes that can be made for the mother with flat nipples and how to evaluate our outcomes. Thanks for listening.